Good afternoon, everyone. My name is Alberta Noonan. I'm from the New England QIN-QIO, and I will be your monitor for today's webinar, Positioning Your Practice for Successful MIPs Reporting in 2018. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing that recording at the end of the webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation, and at that time, I will provide you with instructions on how you can ask a question over the phone. You can also pose a question in the chat box throughout the presentation. Please make sure to send the question to all participants. And we just have to do one other item. There's a disclaimer for this program. The information was prepared as a service to the public and is not intended to grant rights or impose obligations. This information may contain references or links to statutes, regulations, or other policy materials. The information provided is intended to be a general summary. It is not intended to take place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today's presenters are Jill McKenzie and Susan Risman from our Vermont office and Georgette Verhelli from our New Hampshire office. All are consultants for the New England QIN-QIO. At this time, I pass this over to Jill McKenzie.
Thank you, Alberta. Welcome, everybody. I just want to advance the slides here. Okay. So today on today's webinar, we will be reviewing eligibility and how to verify eligibility for MIPs. We'll also be going over changes to the MIPs program, review the program details, as well as provide you with some great, easy ways to report to avoid a penalty or qualify for a moderate positive payment adjustment, or even qualify for maximum payment adjustment. We'll also go over some the cost category and what your practice needs to do now to position itself for successful MIPs reporting in 2018.
Hey, Joe, it's Morgan.
Yes.
We're having some connectivity issues right now, and we actually haven't passed you the ball yet.
Okay.
Jennifer from WebEx, are you on the line?
I'm here.
Jen or Emily from WebEx, are you there?
Can you hear me? This is Jennifer.
Yeah, I can hear you. Can you pass the ball to Jill for us? Perfect. All right, Jill, you should be able to go now.
Okay. Can everybody see the slide overview?
Yes, we can.
Okay, thank you. So we just went over the overview. So let's get started with discussing eligibility. So some things have changed for the 2018 MIPs reporting, and one of them is for consideration to be eligible for MIPs, there's been a change to the low volume threshold. So now a clinician is automatically exempt if he or she is below the low volume threshold of billing less than or equal to $90,000 a year in Medicare Part D allowed charges, or provides care for less than or equal to 200 Medicare patients a year. So, due to this new low-volume threshold, it's really important to determine if you are eligible or exempt from reporting MIPs for 2018. There has been no change in the types of clinicians eligible to participate in 2018. And just to review again, these include physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. So to confirm eligibility, you can go to the NPI lookup tool on the qpt.cms.gov website. And that link is here on the slide. And what you do is you enter your NPI number. You will be able to verify if you are exempt or eligible as an individual and or as a group for reporting. Also, which is really exciting news, CMS will soon be rolling out a new lookup tool that will enable you to enter your KIN to verify the eligibility for all of the NPIs under that KIN. This will be able to be accessed on the QPP website using your EIDM account. So stay tuned. This should be getting rolled out mid to late summer. We haven't heard the exact date yet, but that'll be great for you large practices. So once you've entered your NPI number, or clinician's NPI number into the NPI lookup tool, you'll be able to see a screenshot similar to this. Of course, after we developed these slides, CMS has changed the display that you will see. However, it's very similar, and the information remains the same. It's actually a little bit more enhanced than this screenshot. In this case, the clinician is exempt both as an individual and as a group. So therefore, there's no need for this clinician to report at all. The clinician will not receive a negative or a positive payment adjustment. You can still submit data to CMS, but you're not eligible for a payment adjustment. So this next slide shows that the clinician is exempt from MIPs as an individual, however, is eligible as a group. What this means is that if the clinician is reporting as an individual and not as part of a group, then he or she does not have to report, and they will not receive a positive or negative payment adjustment. However, if their practice chooses to report as a group, the clinician under that KIN must be included in their group reporting. Failure to report will result in a negative payment adjustment. And please note that if you participate in an AAPM, an Advanced Alternative Payment Model, you will be eligible to report as a group, meaning you must report. So this next slide indicates that the clinician is included in MIPs as both an individual and as a group. There is no need to report as an individual if your practice is reporting as a group and includes you in your reporting. So it's really important if you are under your KIN and you look up the lookup tool and say, yeah, I am included as an individual and as a group. It's important for you to make sure that they're going to include you in the group reporting if you decide not to report as an individual. If you think you can get a better score than the group report, however, you can report as an individual as well, and your individual or group score will determine your payment adjustment. Again, failure to report as either an individual or as part of the group will result in a negative payment adjustment. It's really important to note that a MIPS-eligible clinician who is in multiple practices is required to participate in MIPS for each associated practice. So for each associated the KIN/NPI, which he or she exceeds the low volume threshold. So it's also important to make some notes about FQHCs, which are federally qualified health centers, which I'm sure you all know. And their eligibility is determined by Medicare Part B claims only and not payments under PPS. So if a clinician or the KIN exceeds $90,000 for Part B charges and sees more than 200 Medicare patients, they would then be considered eligible for MIPS. We expect that many of the FQHC clinicians will not be required to participate in MIPS based on these new thresholds. However, again, it's up to the individual and or the group to check for their eligibility with a QPP lookup tool. Also, if you participate in an advanced alternative payment model, you may be exempt from MIPS. If you join the AAPM by one of the three snapshot dates, March 31st, June 30th, or August 31st, then you may be exempt. If your APM achieves QP status, which is qualified participant status, you may be eligible for a 5% incentive bonus as well. You can verify your APM status with the APM status lookup tool on the CMS.gov website. This has not been updated for 2018 yet, but we do believe that they will be updating that mid-summer as well. Also, it's really important to check with your ACO about your participation requirements. Now I'd like to introduce my colleague, Georgette Sarhelli, who will present next.
Thank you, Jill.
You're welcome.
Ready to pass the ball. Thanks. I appreciate that. So we're going to talk a little bit about the 2018 program details. And if I can advance my slides. Sorry. There we go. So let's get started with the MIPS performance categories. So they're the same categories that we had in 2017, but the difference is that cost is now worth 10% of your final score. Previously, cost was weighted at 0 in 2017, and quality was at 60 points. Now quality is 50, and cost is 10. And remember, the MIPS final score is compared to the MIPS performance threshold to determine if you receive a positive, negative, or neutral payment adjustment. So let's talk a little bit about performance thresholds and payment adjustments. In order to pass this year, you need 15 points. In 2017, you needed that 3 points. And as you can see, if you achieve the 15 points, you'll receive a neutral payment adjustment, neither a plus or a minus, so that's good news. If you are a high performer and you get equal to or above 70 points, then you've got the potential to get an exceptional performance bonus, which is a minimum of an additional 0.5%, plus an additional positive adjustment that's going to be greater than 0%. If you do fall between the 3.76 and 14.99 points, then you will see a negative payment adjustment, and that's going to be anywhere from 0 to 5%. It will be more than 0 and less than 5. And then, of course, if you choose to not do much of anything and you score between 0 and 3.75, you will get that full negative payment adjustment of 5%. So a quick glance at some of the 2018 changes. So again, the cost category is 10% of your MIPS score, or 10 points, up to 10 points. And previously, it was worth 0. Your quality category is now worth 50 of the MIPS score, and previously that was at 60. Your performance threshold to avoid the negative adjustment is now 15 points and not the 3 points that it was in 2017. We're looking at a 12-month reporting period for quality and a 90-day consecutive days, that is, for improvement activities and the Promoting Interoperability category, which was previously known as the Advancing Care Information category. We're still allowing use of 2014 or 2015 certified electronic health record technology. You get a 10% bonus for using only 2015 cert. We're looking for 60% data completeness, and you can get 5 bonus points for complex patients. You can be reweighted to 0 for quality, improvement activities, and promoting interoperability if you're a clinician impacted by a natural disaster. So an overview for small practices, this is anywhere from 1 to 15 clinicians in your practice. You will get an additional 5 bonus points added to your final score because you're small. You will also be able to get 3 points for quality measures that do not meet data completeness, as opposed to 1 point for larger practices. Virtual group option is available for 10 or fewer clinicians who exceed the low volume threshold. And there's also the hardship exclusion and reweighting available for promoting interoperability. Not sure when they're going to come out with that hardship application form. We're expecting it sometime in mid to late summer. Now let's talk about avoiding the 5% payment adjustment. So the easiest way to avoid penalty is to fully participate in the improvement activities category. So for individuals, groups, or virtual groups that have more than 15 clinicians that aren't in a rural area or a health professional shortage area, you can choose one of the following ways to get the full points. You can choose 2 high-weighted activities, or you can choose 1 high-weighted activity along with 2 medium-weighted activities, or you can pick 4 medium-weighted activities. Any special statuses that are noted, such as the rural area or the HIPSA, you can see that in your MPI lookup tool. So some examples of some high-weighted activities would include 24/7 access to the medical record, so that's same day or next day. Seeing new Medicaid patients in a timely manner is another. And also the consultation of the prescription drug monitoring program through your state's registry. Currently, there are about 93 improvement activities to choose from. For groups or virtual groups with 15 or fewer clinicians that are non-patient or non-patient facing clinicians and or clinicians located in rural or HIPSA areas, you can choose one of the following to get the full 15 points. So that could be 1 high-weighted activity or 2 medium-weighted activities. So just wanted to point out, if you choose to work with your QIN-QIO, some of the improvement activities that you can work right alongside with them on would be additional improvements in access as a result of QIN-QIO technical assistance. And this could be performance of additional activities that improve access to services, such as an on-site diabetes educator or possibly a registered dietitian. Engagement with your QIN-QIO to implement self-management training programs. This especially could be a great opportunity to do the diabetes self-management program, the 6-week workshops that are offered throughout the 6 New England states and elsewhere in the country. Another self-management opportunity could be a self-measured blood pressure program with your practices. Also look at the implementation of antibiotic stewardship program. This is measuring the appropriate use of antibiotics for several different conditions, upper respiratory infection in children, bronchitis in adults, and it's all in according to clinical guidelines for diagnostics and therapeutics. So some other ways to avoid the penalty: submit 12 months of data for 3 quality measures where you can earn at least 5 performance points per measure. Pass the base Promoting Interoperability, which was formerly known as the Advancing Care Information category measures, and a quality measure earning at least 3 performance points. Complete 2 or 1 for smaller practices, medium weight improvement activities, and 2 quality measures earning at least 4 performance points. Or whatever combination of data from quality improvement activities and promoting interoperability categories that will get you to the 15 points. Really important, pick things that you're already doing in your practice. It's so much easier if you're already doing quality improvement projects to pick those as the things that you'll continue to work on. Now, moving. Sorry, my slides are not advancing on my end. There we go. So qualifying for moderate positive payment adjustment, we'll talk a little bit about that. So as you can see in the next slide, here we go. So earning a moderate payment adjustment. So this is where you want to aim to earn 16 to 69 MIPS points. And it just gives you a breakdown that if you choose 1 high-weighted improvement activity or 2 if you have more than 15 clinicians, you'll earn that 15 points. Looking at 6 quality measures to work on via claim through your electronic medical record could earn you anywhere from 6 to 18. And again, it's that difference between being a small practice and a larger practice. Non-specialty specific measures that pretty much anyone can work on include tobacco use, documentation of current medications, your BMI, fall risk, pneumonia vaccine, and influenza immunization. And again, you're guaranteed at least that 1 point if you're a large practice and 3 points for smaller practices for any measure with at least 1 in the numerator. So qualifying for the highest positive payment adjustment. So this is earning at least 70 MIPS points. Here you would need to choose one high-weighted improvement activity or two if you have greater than 15 clinicians at your practice to earn that 15 points. Choosing 6 quality measures to work on through claims or your electronic medical record and earn at least 6 points for each, so that could be 36 plus points. Submit your promoting interoperability measures and earn at least 19 points in that category. And again, these are the PI-based measures that you must pass to earn any points in this category. That includes e-prescribing, security risk analysis, provide patient access, at least one in the numerator again, send a summary of care through your health information exchange and have at least one in the numerator here, or request and accept a summary of care from your 2015. This should be CERT and not CHURCH, but that's your certified, electronic health record technology. So that can get you at least 70 plus MIPS points. So again, promoting interoperability care categories, some things to consider. Significant hardship exemptions are available. Important to be mindful of those deadlines and application requirements. Again, I believe that application will be out mid to late summer. You can keep checking qpp.cms.gov website for further information. And also look at automatic category reweighting for hospital-based clinicians and clinicians in ambulatory surgery centers. And reweighting means that promoting interoperability will account for 0% of your MIPS score, and those points will be reassigned to the quality category. Also, when you consider the hardship exemptions for natural disasters, lack of internet connectivity, EHR vendor went out of business, these are all examples of ways that you can get a hardship exemption. And promoting interoperability-based measure exclusions, health information exchange. For 2014, summary of care, so any eligible clinician who transfers a patient to another setting or refers a patient fewer than 100 times would be exempt here or excluded. And e-prescribing, any MIPS eligible clinician who writes fewer than 100 permissible prescriptions during the performance period would again be excluded. Now I'm going to turn it over to my colleague Susan over in Vermont.
Great, thanks, Georgette. You want to pass me the ball? Oh, perfect. Okay, so let's talk about cost. As we all know, cost is a huge factor, huge problem in our healthcare system. So CMS is including some cost measures that will be weighted toward your overall MIPS score and payment adjustment. So we've talked about it being worth now 10% of your final MIPS score. Do note that this is expected to increase to 30% starting in 2019, although I have heard rumblings that it might not go up that high. But do know that costs will increasingly be weighted higher or more and more as part of your final MIPS score. So it's important to become familiar with these measures. The other thing to note is if you are a clinician or group that's participating in a MIPS alternative payment model, cost is going to continue to be worth 0% of your MIPS score, and that's because the MIPS APMs have other means on which to assess cost. So what are these measures? The two measures in the cost category are Medicare spending per beneficiary and total per capita cost. You may be familiar with these measures if you are in the legacy value modifier program. The measures are the same with a few updates from MIPS. And for both of these measures, your performance will be calculated by CMS using a whole year's worth of data. CMS will hold the claims. You don't need to submit any data for this. And your performance will be compared to other MIPs clinicians during the performance year. So it's not based on your prior year performance. So the Medicare spending per beneficiary measure, it basically assesses the cost to Medicare for services performed by the individual clinician during an episode window. That episode window is 3 days before through 30 days after a hospital discharge. And it includes all Medicare Parts A and B claims during that episode window. It does not include patient copay and coinsurance charges for the hospitalization episodes. Attribution is based on which clinician or group billed the most allowed charges for physician services delivered to the patient during hospitalization. And measured performance may be reported either at the clinician level, which is the TIN/MPI or tax ID number, national provider indicator, or at the clinician group level, or just the TIN level. Do note that the case minimum for the Medicare spending per beneficiary measure is 35 episodes. So you have to have 35 eligible hospitalization episodes in order to get a result for this measure. If you don't happen to have that many episodes, what will happen is that your entire performance for the cost category will be based on the other measure, total per capita cost, assuming you meet the case minimums for that. If you don't meet the case minimums for either of the cost measures, what would happen is that 10% of your MIPS score would actually be reallocated to the quality category, meaning that quality would then be worth 60% of your total MIPS score and cost would be 0%. So moving on to the total per capita cost measure, this is looking to evaluate the overall cost of care provided to beneficiaries attributed to a clinician. And it uses Medicare Part A and B claims to calculate the risk-adjusted per capita cost. And it does include copay and insurance charges to patients. It does not include Medicare Part B. And like the Medicare spending per beneficiary, attribution is based on which clinician or group, respectively, billed the most allowed charges for primary care services delivered to that patient. And it can also be reported at either the clinician level or the clinician group level. The case minimum for reporting is 20 episodes for the total per capita cost. So what can you do now? Because you don't really do anything with cost necessarily. But what you can do is look at what's known as a UR report, or Quality Resource Use Report, to see how you're doing relative to your peers and see if there's anything you need to pay attention to. The 2016 reports are available now. 2017 reports will be available sometime over the summer. You can access those reports by going to the link listed here. You do need an EIDM account, which if you participated in MIPS for 2017, you should have an EIDM account. If you do not and you would like assistance getting an EIDM account, feel free to reach out to us. We will include our contact information at the end of this presentation. All right, so we've covered quite a bit of information here on this webinar, so we thought we would distill it down to kind of what next steps should clinicians take now. The first thing I think folks need to do is decide the level of reporting you want to do. Are you just looking to avoid the negative payment adjustment and report the minimum? Are you looking for a moderate payment adjustment? Are you an overachieving practice who wants to go for that max payment adjustment? Once you know the level of reporting you want to do, it helps guide what effort you need to put into to make sure you're going to be able to submit the required data. The other thing that you should decide pretty early on, if you're a practice, particularly a small practice who does not have an EHR, you have an EHR that was decertified, you want to think about applying for a hardship exclusion. And as I think it was Georgette said, those applications are not yet available. We do expect them sometime over the summer, but I would recommend putting a tickler in your calendar to go look for that on the qpp.cms.gov website. It would be under the Advancing Care Information category or Promoting Interoperability. I don't believe that CMS has updated the QPP website to display Promoting Interoperability yet. And just a reminder, as we mentioned earlier, that is the new name for the Advancing Care Information category. The category is exactly the same. The only thing that has changed is the name. So after that, particularly if you're going for a moderate or a maximum positive payment adjustment, you're going to want to identify your quality measures and make sure that your EHR or your claims submission processes are capturing all the information that you need to be able to report a full year of data to CMS. Really important. So we suggest you get on that right away if you haven't already. The other thing that I suspect pretty much every eligible clinician would probably do, because it's an easy way to get points, is identify and plan for your 90 days of improvement activities. You can get 15 points if you fully participate in that category, and there's almost 100 activities to choose from, many of which most practices are doing at least one of them already. So just identify that time period that you're going to make sure you're doing that activity and collecting the information you need to document that you're doing that activity should you get audited later. And then lastly, for those of you who have an EHR and will be submitting data in that Promoting Interoperability category, you want to look at those base measures that you must pass, such as I'm trying to think here, the security risk analysis, and a few other items that you must pass to get any points in this category. Ideally, you'd also be looking at there's performance measures as well as bonus measures available in this category to just aim to get the maximum points that you can in that category, but you just want to make sure you take a look at those measures, make sure your systems are set up to capture that information and that you're doing what you need to do. And so here, this slide shows a list of resources. Should you want any more information, you can always go to the New England QIN-QIO website. There's a wealth of information about the quality payment program there. You can even ask a question on there. You, of course, can contact any of us individually. We're here to answer questions. Our services are free to you, and we love to help, so feel free to reach out. Also, we highly recommend that you look at the qpp.cms.gov website. This is the Quality Payment Program Hub, where you're going to find all the latest information. CMS is like daily, they're putting out new information. And another thing I just want to point out about the qpp.cms.gov website is there is an About tab there that where you can link to a resource library. It actually routes you to a different website. It's a different CMS website, but there's a wealth of information on here. You can see really details about different quality measures. You can pull up the specs. You can see details about how the cost measures are calculated. And there's a wealth of information there, and it's worth looking there if you have a question about something and want to find the answer. So we've included a list of acronyms here. just because we throw around a lot of acronyms in case you see them or hear them in another webinar. I won't go through them here, but they're here for your future reference. And now I'm going to pass the ball back over to Alberta.
Thank you, everyone. At this time, we'll take questions. If you would like to ask a question over the phone, please press #6. You can also pose your questions in the chat box by sending your message to all participants. In the meantime, I will start reading out the questions that have already been submitted. And the first question is, are SQHCs eligible for MIPs? And can one of our participants answer that? Presenters, I'm sorry.
Hi. Yeah, I did answer that in the chat box, but I will answer it again. This is Jill. Yes, so the eligible clinician exceeds $90,000 for the Part B charges and sees more than 200 Medicare patients, so they would be considered included in this.
And the next question is, what is the threshold for risk scores to be considered complex? To be complex patients? And Jill had responded, if an eligible clinician exceeds, Jill, is that's
no, I answered in the chat box,
okay.
And that was from the previous question.
Okay, so would someone please answer that question?
So as far as, this is Susan, as far as the threshold, just a reminder, this is only for practices with 15 or fewer clinicians. The complexity is based upon, I don't know if you guys are familiar with HCC or hierarchical condition category risk scores. So it has to do with coding, and I don't actually know what the threshold is for that risk score. I'm not sure if any of our other panelists know that either. But I know that, go ahead.
No, I do not know the answer to that, but we'd be more than happy to find that out for you and get back to you.
Okay, and the next question is, where can we find the list of weighted improvement activities?
Hi, and Alberta, I'm sorry, I did answer this in the chat, so I apologize if I was typing too quickly. But for Francis, you can find that on the QPP.gov website that Susan was describing, the Resource Center. They have a wealth of information there. However, if you provide your email, we can send it to you as well.
Okay, and the next question is, what are the chances quality measures will be changed to 90 consecutive days versus full year in 2018?
I would say slim to none. I haven't heard anything about that happening. Looks like from here on out, it's going to be a 12 full months.
Okay. And since ECs must report for all associated practices, what happens if the EC left a prior practice and the prior practice does not report for them?
Well, it's up to the EC. Actually, if they leave a practice, they should be contacting them. If on one of the snapshot dates they're still associated with that practice in their performance year, they need to contact that practice and make sure that they're included in reporting if they are reporting as a group. Most likely, if they're reporting as a group, they're going to include all practitioners. They're not going to go through and say, well, she wasn't here, he wasn't here. So I don't foresee that happening, but it is up to the clinician to contact that practice and ensure that they are reporting.
Okay. The next question.
If they do not report, it's our understanding that an eligible clinician or EC will get a score for each of the practices that they're associated with. And that will, follow their payment adjustment in the end. So you don't want to get a 0 at one of the practices because it will impact things.
Okay. The next question is the 35 episodes for both individual and group reporting?
It depends on the level that the measure is going to be assessed on. If it's just at the clinician level, it would be for the clinician. But if it's assessed at the group level, it would be applied at the group level.
Okay. And then the next question is, for the CERT 2015 bonus, I thought that to qualify, we had to use the 2015 CERT functionality for specific IA activities. For example, patient uploading lab information to the EHR. Hello, presenters, could someone answer that question?
Yes.
Hey, Alex, Georgette. I was actually, can you hear me now?
Yes.
I was going back trying to find that slide, and I haven't come quite across it, but we will double check on this. That makes sense to me, but we'll be sure to put something out to everybody about it.
Okay. For the cost category, could you review again the detail of how CMS will assign or attribute the bennies in order to calculate the cost components? Is there any CMS document with the specifics of the formula CMS? Bear with me one sec.
Yes.
CMS is using to do the patient attribution to each EC.
Hi, this is Jill again. I did answer that question just halfway. There is an excellent document. It's MIPs Cost Performance Category Fact Sheet, which you can find on the QPP website. And I also will send it to the person who asked that question. She did provide me with her email.
Okay, and then someone had asked if the slides will be available post-program. I just posted the information again in the chat box. For cost category, could you again review? I'm sorry, we asked that one already. There is a great cost fact sheet on the app website that walks you through this, or provides your email, and this is from Julie. She said she will send it to you. From Alex, I need help. Could someone contact me at apos@opt? Okay.
And she also
we'll post that question on, and then
and
security analysis.
UI director. So we'll pass it on to our team in Connecticut, and they will be reaching out to you, Alex.
Okay. Is the security risk analysis every 365 calendar year, or it has to be completed during the 90-day attestation period?
I believe it's once a year.
Yeah, I agree, Susan. I believe it's once a year.
Okay. The next question is, we have a provider leaving mid-year. If we don't report their information with our group, who does the adjustment affect? The group or the individual?
Generally, the payment adjustment follows the individual. But it does depend somewhat on how the billing is done.
Okay, and then someone answered more detail on the risk analysis question. They said security risk analysis needs to be done every reporting period. We also have a question, how do you create an EIDM?
Hi, it's Georgette. Well, as I like to tell my practices, getting your enterprise identity management account set up is maybe one of the more painful things that you'll do, but I will post the site that you need to go to in order to get that EIDM account set up.
Okay, the next question is PI. If an EP is in an ACO and transfers or refers less than 100 times, should provider statistics be included in the MIPs reporting?
I think I need more clarification on that question. It depends if they're going to be still included in the PI category because they have to report as being a participant of the ACO. I'm not sure if that answers their question.
Penny, could you maybe reach out to Jill via email? Her email is posted on the screen, and she could give you more detail.
Thank you.
And then, does this apply to a group with physical therapists and chiropractors less than 15 clinicians?
Well, physical therapists are not included as eligible clinicians this year. The chiropractors are. So I'm not sure what they're asking if what applies to the group.
So if the chiropractors in your group are billing, are over that low volume threshold of 90,200, then yes, it would apply to your group. If the chiropractors would be eligible, and you do have the option to include others in the group if you like, but you don't have to if they're not eligible clinicians.
Okay, and the next question is, does PCMH accreditation still satisfy the IA category in 2018?
Yes, it is our understanding that as in 2017, if you are a patient-centered medical home, you can attest to that in the improvement activity category and get the full 15 points for that category.
Okay, and the next question is, if the provider is exempt from MIPs, can he report?
Yes, a provider can report if they're exempt from MIPs. However, they will not receive a positive or a negative adjustment score. And we suggest, if people want to do this because they think next year they're going to be eligible, this is a great trial run. So we would encourage you to do that, but that's completely optional.
Thanks, Jill. The next question is, hello, we are a small practice, 2 practitioners, that is part of an APM. What guidelines should we be following? For example, the improvement activities for the small practice or the large practice?
So, Katie, it depends on the type of APM that you're participating in. If you are in what's known as a MIPS APM, you would be required to just submit data for the Promoting Interoperability category. So you'd get automatic credit for the improvement activity category, so you don't need to worry about that large and small. The APM would be doing the quality stuff for you as well as the cost. So the only thing you would be responsible for is that Promoting Interoperability category. If you are part of an alternative or an advanced alternative payment model, you actually don't have to submit anything from this, assuming that you are what's known as a qualified participant, and you would need to check with your ACO about that or your advanced APM. you would do all your reporting through them. So you can basically, ignore the MIPS categories.
Okay, the next question is, by allowed charges, do you mean allowance or the actual charge when figuring the $90,000 threshold?
That 90,000 is figured based on allowable charges, Part B charges.
Okay. How does CMS know who you are reporting for when reporting as a group?
So, CMS, when you set up an EIDM account, well, first of all, CMS will determine eligibility of everybody in your group based on that low volume threshold. And, if you go to report and you set up an EIDM account, you will see the clinicians, the eligible clinicians linked to your PIN. And that's how they know who you're reporting for. You actually identify them.
Okay, and are physical therapists included this year?
No, they're not.
They're not.
No, they're not.
And I believe that's the end of the questions. Did anybody have any more questions? You can either insert them in the chat box or you can do #6 to unmute yourself. In the meantime,
I'd like to add just one comment to how does CMS know who you are reporting for when reporting as a group. If you belong to an ACO, it's really your responsibility, your team's responsibility to go discuss this with your ACO. Make sure that all your NPIs under your TIN are on their participation list because they provide that to CMS. So I just want to put that out there as well.
okay. Also, to follow up on that question about physical therapists, the question is, should we start preparing for this, the PT office?
I would encourage everyone to start preparing because you just don't know when they're going to add additional providers to that list to need to report.
I agree, and it's good. It's just good practice to make sure that you're working on quality measures and working on improving practices. So I would encourage it as well.
Excuse me, can you hear me?
Yes.
May I ask a question?
Yes.
Okay, so I'm still confused on the MIPS individual and group exemptions. So say I'm in a practice of 3 providers and I put in the NPI numbers and one of us is exempt because we don't meet the low volume threshold, but the group is not exempt because as a group we charge more than $90,000 of Medicare Part B billing. So if we decide to submit as a group, my understanding is all 3 of the clinicians' data will be included, even me, even though I'm the one didn't meet the 90,000 charges on my own. So I've gotten 2 different answers on this, so I'm still confused. So we do the group reporting, and it's just based on the TIN. There's no NPI, I don't believe, associated with that data. So when I went to CMS with the question, they wrote back to me that the only people that will get the adjustment, the negative or the positive, are the 2 out of the 3 that are actually submit more than the 90,000. So even though you're doing a group, your 3 people's data is going to be in there, but only the payment, negative or positive, will be set to the 2 folks. I just don't understand that because I'm hearing different things. Can you help me out?
Well, my understanding is that, okay, if you look it up in the lookup tool and you're exempt as an individual but required as a group, if your group is reporting, then you should be included in that. I can't see why a group of 4 physicians would be eligible for reporting MIPs, but yet one of them wasn't. I don't know if I'm confused anymore. If one person in the
well, I could be someone that just doesn't see a large mix of Medicare patients, but I'm in the group, but my other 3 partners, you know, do the lion's share of that 90,000.
Correct.
So if we choose group reporting, my data is still going to be included in the data that they get judged on. So I was thinking right?
Yeah. But the threshold is going to be based on the group, not on the individual.
Right. So my data and the other 3 people's data, it's all, regardless of who's eligible or not, we're eligible as a group, so our data goes in, and then we get a group score. How do they actually do the payment, the adjustment? Say we get a 3% payment adjustment. How does it actually get applied then in, let's just say, 2020? Is it, that's what I'm trying to figure out.
All receive the same group.
Dr. Jill, we're almost out of time. Could you take that offline? Just, I'll put the screen back to the contact information for Jill.
Okay.
And in the meantime, we are almost out of time. So I want to thank everyone for a great discussion. I have a few last-minute announcements before we end today's call. Reminder that we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as the link to the event page of our website. The slides are available on the event webpage, and within the next few business days, a recording and transcript of this webinar will also be added. I'll put that link in the chat for you again. Thank you for attending, and have a great day.